This is Minda Wilson with Urgent Care. I'm excited to welcome to my show Dr. Ron Genova, who is developing a new model for healthcare. Welcome, Dr. Ron.
Well, good morning, Mindy. How are you doing this morning?
I'm so excited to be talking to you. So, how did you come up with this idea, and tell us about how you got it implemented?
Well, we opened up what we call a physician-owned hospital, known as Phoenix ER and Medical Hospital. It's based out of Chandler, which is a suburb of Phoenix, Arizona. We really wanted to get doctors and patients back together again, and our model really kind of puts the doctors back in the position of actually being a patient advocate. Unfortunately, with all the developments that have gone on in medicine for the last 40 years, the doctor has been sidelined away from patient care, and patient care decisions are actually made by other entities, insurance companies, government agencies, various other entities, essentially taking away that relationship that is absolutely key to healthcare.
And so, because what happens is what the insurance companies pay for, people tend to do, and what they don't pay for, even if somebody needs to do it, they're unlikely to do. Is that basically how they maintain control?
That is true. One of the economics 101 lessons that people fail to remember is the person who actually pays the bill or has the money is the actual customer. So people forget when they actually get a third-party insurer to act on their behalf, the insurance company becomes the quote-unquote customer, and the patient is taken outside of that loop. So then the patient really has no choice then if they want to have or they need a particular procedure or a particular medicine or a certain various counseling services or other services that they need healthcare-wise, and the insurance company doesn't approve of it, then the patient is left out of that loop.
So how does the standalone ER or micro hospital change that dynamic?
It puts the doctors back in the only position left where the physicians can actually advocate for the patient. For example, if you do come into our emergency department, we're only going to get the things that you absolutely need. There's a lot of padding and there's a lot of things that happen in medicine that a patient would not necessarily be aware of. And it adds cost to the system. There are overcharges that are always associated with that as part of the Rob Peter to pay Paul system that our system has become. So patients just are not aware of some of the things that go on in the background that aren't really in their favor. So the physicians themselves really are the patient advocate. We really are looking out for the patient's best interest and their safety.
But you're still dealing with the insurance companies. So how does what you do allow you to change that?
First of all, there's just a matter of ethics and morality. Our system really emphasizes economics over some of those issues. Yes, we do have to deal with insurance companies, but at the end of the day, we also emphasize what really is a cash pay model, because there's so many built-in padded expenses into our current system. Oftentimes, the bill or the explanation of benefits that the patient sees is 300, 400, or 500% marked up from what the actual costs really are. And if you were going to act in your own self-interest, you would obviously want to pay really what it costs to access that care, not some kind of inflated type of measure.
And the fact that it's doctor owned, does that make a difference in how you conduct yourself? You get the decision making power, right? So you can make decisions about patient care.
That is correct. Part of the trend in the last 50 years has been to disempower the clinicians. And in doing so, the clinicians now are outside of that patient care loop. It should be patient-physician. That's our emphasis. That's the core of all medicine. It goes back thousands of years. It goes back to our Hippocratic oaths. That the relationship between the patient and the doctor is the paramount relationship. And of course, there's the nursing component of that. Part of our whole relationship is really kind of a triangle. There's patient-doctor, there's patient nurse, and then the relationships between the patient and the nurse as well. Those are the key relationships in medicine. And unless the organization is doing its best to sustain that particular model, everything else takes away from patient care. It's just a barrier.
So in these times of COVID-19, a lot of hospitals are seeing major hits because they aren't allowed to do procedures that aren't essential, I guess is the way to put it. So is that changing your model too, or are you still allowed to take all comers?
We can take all comers. We actually, if you think of us as a kind of a small community hospital, some of the advanced procedures like surgeries and things like that, since this was our first or initial effort, we didn't go out and design an ICU or critical care area or have big operating rooms or things like that. So we're not susceptible to those same kinds of economic pressures. Unfortunately, things like elective procedures and surgeries, for the major hospitals, that's a profit center for them. So when you take away those elective procedures, all of a sudden you're left in a position of not having any margin to work with in order to make money. And that's just simple economics in medicine. Because of the way the system is developed, things like elective procedures and things like that are markedly better reimbursed than routine medical care, for instance. Our payment system is very biased towards procedures and things rather than the cognitive aspects of medicine.
Mm-hmm. So you're sort of flipping the model on its head in a way. You're saying you're empowering doctors by giving them an ownership interest, and that gives them a say in how the practice of the clinic is conducted. And then you're allowing them to make the financial decisions by putting them in a position where they can negotiate directly with the insurance companies. And by empowering the doctors, then you're giving patients power because they're able to deal with you're dealing with the owner, right? If somebody comes in and sees you, they're dealing with the owner of the business. And then you can make decisions about the business, about the level of care, because it's your business. Is that essentially what you're saying?
That is precisely correct. We're trying to take all the hands that are in the pot. We're trying to get rid of all those extraneous hands.
And then that gives a better relationship for everyone. So it's sort of the traditional small town model where people are dealing with people they know, and you have a relationship with the people in charge. And then in that way, not only are you empowering the doctors, but you're also empowering the patients because they can make decisions that aren't necessarily based on what coverage they have, because you have a cash pay option as well.
That is correct, and it's so hard for anyone to make any comparisons, because this is one of the big problems in medicine, is that it is very obscure. You can't find, say, for instance, you can't find how much it would cost to come in for an emergency department visit. We actually do that for the patients that request that particular service. They know beforehand what the price of the care that they will cost, and it's very economical. So, for instance, I would say fairly routinely, our actual cash prices would be at 20% of what the actual insured charge would be, and that's fairly routine.
So, right, and 20% is the copay. It's less than the copay for going to the emergency room. Copays now are up to 50%. So people might actually do. Yeah, so people may actually fare better by going to a place like yours because you're able to control the costs.
And that's correct. And it's an upfront type of discussion too. It's there, in medicine, there a lot of times things happen and you don't know what it's going to happen. Sometimes the physician doesn't know, only because of the nature of how the results come back or how things progress during the course of the workup. There are always curveballs. It's not something that's easily predicted. So So
Right.
the physicians are assuming a lot of that risk for the care, as is the patient. So there's a shared risk and there's shared accountability.
That's fantastic. So fantastic. And then so this is your first foray into the field, and it's working well?
It is. We just finished our first year. We had our 1 year anniversary this past March. Of course,
Congratulations.
COVID kind of. Well, thank you very much. And COVID kind of threw a little bit of a curveball to everyone, or a
Hmm.
large curveball, or a slider, or using baseball analogies. But we've continued to see our patients. We set ourselves up to be COVID ready too, because we're a small institution. We can move very quickly and make changes and change processes in a way that took other people months to put together.
And the other thing that's interesting is a lot of people have been afraid to go to emergency rooms because of COVID that have diseases that uh, might require intervention. So a place like yours, they can come and they can be safe and secure in that environment.
That is part of the excitement about we're able to get back patients back very quickly. There's no waiting room time. We have separated areas for, I'm going to say, COVID, non-COVID, in terms of care areas and zones. So we've really tried to do really essentially what would be common sense, which is people whom you suspect may have the virus or have all the symptoms that would make you suspicious. They're separated out from what otherwise would be a general population, until confirmatory tests can tell us, what direction to go next.
So it's like when my kids were young and I took them to the pediatrician, they had the sick kids entrance, which was separate and apart from the main entrance to the practice.
Correct. And because we're such a much smaller institution, obviously some emergency departments see several hundred patients a day, where we might see anywhere from 10 to 30, depending on how the volume progresses during the day. You just have that much less exposure. It's just simple numbers and statistics.
Right, and the estimate for this year is that 12% of hospitals are going to close as a result of COVID. So this is a model, and most of them are going to be in rural areas. So this is a model that could actually be a replacement for those hospitals that are closing.
Yes, rural medicine is in dire straits. It's been a long time coming. Again, the pendulum is going to swing. It swung very, very, I'm going to say, far to one side in terms of centralization of medical care. That's been because of economic forces. As time progresses, we're going to find that the pendulum is going to have to swing in the other direction. We're going to need to decentralize medicine in order for it to be safer. And again, some of that is economic. Some of that also has to do with, just the question of what the demographics are. Most of our populations are in the big cities. Therefore, most of the economic activity tends to be concentrated there. And unfortunately, the smaller hospitals still have fixed costs, regardless of how many people show up at the front door.
Right, but with now that we've had sheltering in place, there's going to be that centralized city model may also be changing. People may.
I think absolutely.
And you were saying saying how you thought it might change.
I do think it will change. In fact, overall, I think COVID has highlighted certain trends that have reached an apex. The urbanization of America, the desire to be concentrated in the city because that's where the jobs and the economic activity is. I think COVID is going to really highlight to people that there may be benefits to being in a rural area, to being in a less populated area, and so that pendulum may swing back. So our farming communities in rural areas that have been economically decimated over the last 30 years may actually see a significant comeback. That's a trend to keep an eye out for.
And by changing the model of care delivery and turning the model back to physician-owned practices, you're taking us back to a time when people had a relationship with their physician, because originally, every doctor was their own boss. They had their own practice, and people would go see their local physician. And now we've sort of institutionalized medicine, and people don't have a relationship with their doctor anymore. But in a smaller setting, a smaller community, you're sort of swinging the pendulum back to that.
That's right. We we may be the very first or the very first vanguard of making what's old new again. It's going to take time. It's going to take a lot of effort, and there's going to be significant headwinds because there are very, very powerful economic forces that is causing things to be concentrated for cost savings. But as we can see with this whole COVID crisis, that it's a very, very delicate chain of events. If part of that chain breaks down, all of a sudden, whether it's economic activity or medicine, if those chains break down, then there's nothing. So we have to build some redundancy back into our system, even though it may cost us a little bit more as a trade-off for safety, because anymore you can't just rely on the fact that something's going to be there when it's just in time and there's no dime left.
Right, exactly. Because, if we have, anytime you have an epidemic like this, or you have, there has to be a system in place to manage that concurrently with people receiving their regular care. I mean, if you're a diabetic, you still need your insulin. If you're on a dialysis patient, you still have to go to dialysis, even if there isn't a COVID epidemic, so you have,
that is true.
And
That's
preventing.
I'm sorry. I think COVID just highlighted weaknesses in the system that were already there and have come out to the forefront. So we obviously had planned this prior to there being anything such as a COVID, because I'd like to say we recognized the weaknesses in the chain.
So how do you perceive the shortfalls of the system that your model has addressed?
Well, the main shortfall is that the physician-patient relationship has been interfered with. And that's our primary objective, is to get it back to its roots and get it back to its most important relationship. That the physician and the patient have an inviolable relationship, and everything else in the system should do its best to support that rather than interfere with that. That's really the primary objective.
And so in an emergency setting, how do you build the relationship with the patient outside the emergency setting?
At the end of the day, this is a matter of building relationships with the community and having that hospital be the focus of these built up relationships.
So explain that a little more. So I come into you, I have you've identified maybe something that needs addressing that is not something that can be addressed immediately in an urgent setting. So how you've built a relationship with me, how does that continue on so I make sure I get the care I need?
Well, again, this is a matter of building relationships between clinicians of the same mindset. Mm-hmm. Every physician that we go talk to, if you have to ask them, well, what is the thing that's changed so much in medicine that you would like to change? And their first answer back is, I want to be able to take care of my patients without everyone having a say in that conversation. Mm-hmm. And so building those kinds of relationships is our step 2. Mm-hmm. and 3 and 4. So we're in the process of building out a network of physicians that are like-minded, that mm-hmm. value that relationship above, say, insurance relationships.
And do you have an outpatient facility where that patient may be able to come back and see you again, not on an urgent basis?
At this point, we do not, but that is in the works.
So it's a long-term plan, essentially, to re-engage the doctor-patient relationship and make that the primary focus of medicine, and sort of cut out the people who have benefited economically but have not added to the practice of medicine. Cut those people out.
That is correct. At the end of the day, everyone is looking for a value-added proposition. If you look at the statistics, the actual number of physicians working in the community hasn't really changed. It's gone up by a few percentage points every year. The economic costs of the physicians has stayed relatively flat. Meanwhile, the administrative costs have gone up by about 1,000% over the last 20 years.
Right.
We don't see any value in that. That's not valuable to the patient to
Right.
have administrative costs that eat up 90% of your healthcare budget.
Right, right. So for hospitals, in the year 2000, administrative costs are one out of every $4, and now they're almost one out of every two that they take in revenue. So
that is correct. So there's a misdirection of resources away from the patient and away from the clinician.
yeah. So this allows, by reducing the administrative layers, you have a more effective use of the dollars spent on care. It's
in a $3 trillion system. There's probably, if you look at all the different studies, there's anywhere from 20 to 50% waste. That's $1.5 trillion, and that's every year moving forward. We just feel that patients and the system deserve a better value for what we're getting for those dollars.
And so if people want to reach out to you or go to your facility, what's the best way to do that?
The easiest way is to find us online at phoenixerhospital.com. That's our website. We have educational links on our site. We have our address. We have our location. People can also review our Yelp and Google reviews. These are 100% organic reviews. We're proud of the fact that we're virtually a 5-star or 4.9 star institution where people have organically come back and said, wow, we've had such a great and unique experience that we're going to rate you highly. And we appreciate all their feedback. And obviously in areas that we can improve, we're in a position to do that very quickly. And in areas where we excel, we can continue doing that.
That's amazing. Dr. Ron Genova, I really appreciate your time. And if doctors are interested in duplicating your model, can they also reach out to you through the website as well?
Absolutely. That would probably be our best contact number. I'm going to say that's the best contact for us, because this way we can the whole team can actually see exactly what it is that we're focusing on.
It was a great pleasure, and I appreciate you taking the time to come. This is Minda Wilson from Urgent Care.